Hello everyone. This presentation is Chronic Care Management in a Critical Access Hospital Setting. The author is Ruth Ann Knox, nursing student at Fort Hays State University, and this is for Nursing 449. The community being addressed is Mineola Healthcare. It is comprised of 3 clinics, a long-term care unit, and a critical access hospital. The Critical Access Hospital is a 19-bed facility located in Mineola, Kansas. This was founded in 1956. The community in which this facility resides is in rural southwest Kansas with a population of 700. There is also within the community one of the clinics and the long-term care unit. They're all connected as one. The average number of inpatients per day in the inpatient hospital is 4. The sponsoring hospital is Hays Medical Center in Hays, Kansas. The closest trauma center is in Hays, Kansas, which is approximately an hour and a half to 2-hour drive from Mineola, and that's a level 3 trauma center, and the closest level 1 trauma center is in Wichita, Kansas, at either Wesley or Via Christi facilities, and that is also about a 2.5 to 3-hour drive. The closest certified stroke center is Via Christi in Wichita, which is 2.5 to 3 hours away. So this makes our setting very rural. This is an image of the Mineola District Hospital. To your left, where it says Mineola District Hospital, that is the clinic. To your right is the inpatient space, and throughout there is the lab that they do inpatient and outpatient lab. There's x-ray. They also do inpatient and outpatient. There's also a CT room. They do inpatient and outpatient CTs also. They also do sonograms. There is PT within the facility, and you can do inpatient or outpatient physical therapy. They also have an operating room. Operating room has approximately 8 procedures. They usually do those on Thursdays and Fridays, and those, depending on how difficult the procedure is, depends on how many they have in a day. And they can do laparoscopic procedures, open procedures. They can do wound debridement, upper and lower scopes. They do not do joints. They have a 3-bed ER also. There is 2 bays in one room and 1 bay by itself. They have treatment rooms that they do as outpatient. Those include wound care, either wound dressing changes or wound vac replacement. They also do IVs outpatient in the treatment rooms, and the treatment rooms are either in an ER room if it's available or an inpatient room depending on the volume they have going on. The IV treatments that they do are either IV antibiotics, they can do blood products, they can do Ferlicet, which is IV iron. They can also do immunoglobulin, which is a type of immune protein that helps your immune system. They might give you IVIG or whichever one you may be lacking. They can also do swing bed in their inpatient space. In the clinic, they can do small procedures if needed, stitches or some wound care. They do have a treatment room within the clinic, but if it's too intensive or if insurance requires it, they might have to do a treatment room at the hospital for coverage. In the back is the long-term care. It is a 36-bed unit, and so all of these facilities are connected. The 2 other clinics that are associated with Mineola Healthcare is in Buckland, which is about 23 miles away to the east. The other clinic is in Fowler, Kansas, which is about 11 miles away to the west. And they can do lab draws and deliver them here to the main lab for processing or to be shipped out. The community in which Mineola Healthcare serves has very high standards for their healthcare. Health is very important to those in the community, and the majority of the community are adults over 65. There are, of course, younger adults, families, but the majority are older adults, and they do hold their health at a high standard and prefer to have the best health care available to them. Patients prefer to turn to their providers and the nurses within the clinics and the hospital to give them guidance. They don't tend to research on their own or do home remedies. Patients within the community believe health is a right that must be preserved and taken seriously. The majority of the population believe in preventative health care and push to have preventative services available. Some of those services that we have an organization called WePAC, and it is for females at this time. They are starting to pay for some male screening, but at the moment it's mostly female screening, and that's for preventative care for any woman residing in either this community of Mineola. There's also 4 other rural communities around us that they will cover. Those areas are Wilmore, Kansas, Englewood, Kansas, Protection, Kansas, Ashland, Kansas, and Coldwater, Kansas, and they will pay for either scopes or breast screening or even some lab screening. And in the fall and spring there's health fairs, and the majority of the people that come, they are pretty large health fairs, are those 65 and over. And they're very good about making sure they get their lab work done. They follow up with their provider after the health fair to find out the results. Those results are mailed to them, plus the provider gets them. And usually they're contacting the provider before the provider has time to even talk to them about what their results were, especially if they were different from the previous health fair or if they had blood drawn more recent than that. And usually the fall health fair is in October. Spring health fair is usually in March. And there's also other entities that come to the health fair. They also do blood pressures. The EMS service within the community comes and does blood sugar checks as well at the health fair. And there's other areas around that have vendors come and set up to visit with those people. The majority of the community are either Christian or Methodist, and they believe that health is a spiritual part of everyone's being. There are some other minority groups within the community, and all of the facilities, hospital, clinics, they all try to provide services for those. Special diets for health reasons are observed within the hospital, but most of the people in the community do not correlate food with curing disease. Some denominations feel like some foods have healing powers, or they promote curing a disease, but our community does not. The majority of the community are female, and the overall belief is that couples are to be addressed together regarding care concerns. This is in any of the spaces, either the clinic or outlying clinics, hospital, and long-term care. All of those areas, the couples want to be addressed. If the spouse, the wife, is having a procedure done, the husband wants to be involved, or vice versa. It's very family oriented. Also, if they have children, the children usually want to be involved also. The cultural change for more advanced preventative care is very important to those in the community. It's really not a stagnant culture. They really want to know what's the best preventative care they can have, or what is the most recent thing out there. There's a walking group. It's mostly comprised of those over 65, but anybody can be involved, and they like to walk throughout the community. There's a new park to the south of the town with a nice big walking trail, and a lot of the seniors like to walk. They really like to stay healthy and know the best practices. The majority of the community do not have health superstitions. Most of them would actually prefer to be admitted and cared for when they're ill, instead of just having clinic visits or outpatient treatments. They really want that hands-on care for them. That's what they've known. even as the previous generations, if you were sick, you went to the hospital. And that's kind of their thought process. They really want to prevent going to the hospital. But if they are sick, they would rather be cared for instead of kind of doing their treatment on their own, or coming in and just having a few treatments performed and then going home to kind of recuperate on their own. They really like that hands-on care. The mission statement of Mineola Healthcare is to deliver personalized, patient-oriented care in an atmosphere that promotes the healing process and provides enrichment to the communities we serve. On MineolaHealthcare.com's website, they do have multiple things talking about how they like to deliver care to their patients. This next area is just kind of a small subset from their paragraph. The nursing staff at Mineola District Hospital are dedicated leaders, putting all efforts forward in meeting the needs of our patients. Let us know how we can address your needs. We care about your health and recovery. They really are patient-focused. It's not all about dollar amounts or anything like that. They really want to make sure the patients and their families are well taken care of. The facility does not have a religious foundation, but they are very dedicated to observing religious beliefs of their patients. For example, they do have what they call a ministerial alliance, and that is all of the pastors within the community. They have a group, they come in if needed, they take turns coming in if there's a dying patient or a family in need of just some spiritual healing. There's not a whole lot in the community that are Catholic, but they do have several patients that come in either from surrounding communities or within the community that are Catholic. If they need to see the priest, they do have contacts with a local priest. All leaders, clinical and non-clinical, perform daily rounding with inpatients to ensure their needs are met, and from hour one as a patient, discharge planning and patient continuity of care are priorities to them. They really make sure that everybody's taken care of. If there's a concern, they go to whoever they can to address it. If it is about a payment arrangement, they go to billing right away. Because the facility is so small, billing will go straight to the patient in the patient room, discuss with them what they need, if they need to make certain payment arrangements, whatever they need to do. They're very open to help everyone. If the family is in need of something, they will call whoever they need to help them. It's very close-knit community. They really care about everyone. Most everyone knows each other. And if they don't, like if it's a new patient coming from a surrounding community, they still try to rally together and help them. It's just a very caring community. The issue that is of concern to this community is chronic care management of diabetes and heart failure upon discharge from the hospital. That's something they really see as a big issue, especially in the inpatient space, which it affects all areas. If it's a long-term care patient that has these diagnoses and they keep coming in, or if it's a clinic patient that has these disease processes and they keep coming into the hospital. So it's, a big circle, and the biggest thing is they want to try to do some education and management of these diseases. These are the biggest two. Obviously, there's other chronic conditions out there that can cause readmission rates, but these two are the biggest ones that this facility sees. And so they really want to tackle this. And so the questions associated with this issue that need to be answered are, how can readmission rates be reduced with chronic care management? And what is the impact on the patients in this community with the implementation of a chronic care management professional? They have multiple, most of these people with diabetes or CHF, they have other comorbidities. And, that's usually kind of what brings them in. Returning, a lot of times they'll be discharged and within 30 days they return with complications from their diagnoses. Studies show that 20% of heart failure patients are readmitted in 30 days and 60% are readmitted by 6 months. Kind of the same goes for diabetes. and studies show that 14.4 to 22.7% with diabetes mellitus are readmitted in 30 days, usually related to blood sugar issues, or complications from the diabetes. And so these are the biggest two that they see as their readmission rates. And that doesn't just affect the hospital, it affects their whole healthcare system. And some of the things that they've tried to do to combat this issue, the nurse managers and providers, that they've used the Cerner system, which is kind of their whole system. It has their providers can go in there, they can do orders through there. It's just their whole medical system. And you can go in there and print out forms providing education on those disease processes and how to prevent worsening of the diagnosis, or how to see symptoms before to kind of do some tertiary prevention. And those have had minimal impact. They keep seeing those patients come back in, even though they've given them this education. The biggest problem with this readmission, especially of these two big ones, is that patients and families or caregivers, their lives are extremely affected by the repeated relapse of these chronic health complications. The patient could potentially die from these diagnoses, and it's stressful for the families and caregivers, especially if the families are the primary caregivers. It's just very stressful. Sometimes the patients are on their own and they have a hard time managing themselves, especially when they don't have anybody else to rely on. And the second biggest problem with this readmission rate, especially, is that it affects reimbursement, and they can be penalized for having readmission rates for these patients. So the higher the readmission rate, the lower the reimbursement they're going to receive, and that affects the whole unit as a whole. And the CEO and other management professionals are looking into chronic care management, especially they want an RN or an LPN in the clinic that's connected to the hospital. But what they're looking at is this process through CMS. So Medicare patients would be the only ones to receive this at the moment due to the reimbursement of it. And they would like to expand and provide services to other patients in the clinic besides the Medicare population as the program progresses, but they don't have this set up at all currently. And even though the Medicare patients are the ones that's going to benefit, and it's a large majority of their patients, they would be limited to one visit per month, and there's special implications on how that process works for reimbursement. And so they're having, some time trying to figure out all the quirks to that before they even get that started. So having somebody in the inpatient setting to provide this education, and they could utilize that person throughout the whole facility, would be kind of a broader, better addition than what they're looking at right now. And you could even have this chronic care management nurse in the clinic to do this once they get that process rolling out. But the bigger picture that is being looked at is having somebody available for all patients, not just Medicare patients, because you do see the Medicaid patients. There are some private pay patients as well. There are several limitations to what provides a big basis for why this is an issue. Part of it is a rural setting, and also they're doing all of this education and all of this follow-up, and it's still having a hard time. Mineola District Hospital is involved in HCAHPS, and there's all of these surveys, and it goes out and it compiles the big survey results, and it's posted out there for anybody to see where hospitals rate compared to others in the surrounding area. You can do a hospital compare type thing on the website as well. And so involving this HCAHPS, the nurses pride themselves in assuring that all aspects of the survey are addressed with their patients, and that they have all the information about their admission diagnosis and any other associated diagnosis before they're discharged, and they go over everything Is your pain controlled? All of those questions that are involved in the HCAP survey that they will be called after their inpatient stay and asked these questions, and they try to go over them to make sure that they're fully educated on everything they need to know. And that still has not been completely effective in preventing those readmission rates for diabetics and those with CHF. The management teams also got involved by kind of doing some follow-up phone calls to ensure the patient understands everything. You know, did they get their discharge instructions given to them in paper form and verbally spoken to them? Do they understand their medications? Do they have a follow-up appointment? If not, helping them get that set up. And those interventions have not been effective in preventing readmissions either. You know, and it's really hard because the services around the community are very limited. And this is a pretty rural setting. The health department sits in the county seat, which is about 30 miles south of in Ashland, Kansas. And it's just a one nurse department. And she does come to Mineola and do some services, but it's really just vaccinations. And it's just one Thursday a month, so that's kind of limited. She does try to do some educational things, but mostly it's in Ashland, so if you want to be involved in some of her educational outreach things, you have to go there. And for a lot of people, those that can't travel, it's hard. EMS is a BLS county service. There's 2 ambulances that service Mineola, and there's also ambulances in Ashland that service that area. And they try to do some educational things yearly on, you know, heart attack, stroke, things like that at the community center to educate those in the community, you know, but that's kind of hard to do too because they are volunteer service. So there's not always enough volunteers to present those kind of things. And it's just kind of a struggle there. There is a civic center, and they serve meals Monday through Friday in the center, and some of those that are more homebound can have accommodations for home delivery, but you have to set up arrangements for that. And the Civic Center also provides meals for a couple communities 40 miles to the west of us that do not have like a Civic Center or any other kind of system like that. So it's kind of a Meals on Wheels for those people over there. And that's really it for in town. I mean, there's some churches. There's a community church, Christian church, Methodist church, and, you know, they kind of come together and kind of help. They don't do a whole lot of outreach things involving health, but they do come together and help people in the community as they need help. And so basically, I mean, there's some small businesses, but that's it for really healthcare. Area on aging, SRS, and there are a couple home health agencies 20 miles to the north of us in Dodge City, Kansas. But those home health agencies are very limited on the services they provide, and you have to be homebound, which in their definition, this means that you cannot drive. You have to be homebound. You can't go out to the Civic Center every day or go shopping. You know, you have to basically stay at home. People come to you for services. But even then, the home health is just, they come in maybe a couple times a week, ensure your medication is all set up correctly, and then maybe give you a bath once or twice a week. They don't really provide hourly care. You know, in some bigger areas, you can get home health where they stay in your home for 8 hours a day or whatever your need is. But those services really aren't available in these rural areas. So, and having educational programs, it's pretty sparse. If you want, there's a little bit more educational programs about dementia and stroke, heart attack, all of those things that are a little more in-depth in Dodge City. But, you know, people that have a hard time driving or can't drive, getting there is pretty hard, and there's not really transportation. You know, there are some medical taxis out of Dodge City that will take you to doctor's appointments, and they can take people in our community to appointments, but it costs a lot of money to travel like that, because especially if you have an appointment in Wichita or somewhere that's over 100 miles away, it costs a lot of money for those transportation services. So there's just not a whole lot of care agencies or educational avenues to help those that have kind of that chronic care need. The 3 clinics associated with Mineola Healthcare see approximately 50 patients a day, collectively between all 3 of them. The 2 outlying clinics, the one in Fowler, Kansas, and the one in Buckland, Kansas, are staffed by a provider, and it's usually, they don't really have a full-time provider to provide services in those 2 outlying clinics. So usually between the providers, they go every Wednesday, or they go every Tuesday and Thursday of every week. So they'll kind of share in keeping that staffed, and they have services Monday through Friday. And they only treat about 10 patients a day. I mean, sometimes more, just depends on how long they're in the clinic. Mineola sees around 30 of those 50 patients in a day. And they also have clinic hours Saturdays 8 to 11. And they average about 5 patients on Saturdays if it's a booked day. Just depends on what the patient need is and how long the appointment might take. There are 5 medicals, MDs, 3 PAs that provide care to the patients for all of the clinics. There's one provider that all he does is surgical procedures, and so he will not see a patient unless it's for pre-op assessment. He won't see you for anything else. These providers also see the inpatients, depending on whose patient it is or who's covering the inpatient space, especially if it's on a weekend. And they also cover the ER. And 2 of the MDs perform surgical procedures on Thursdays and Fridays. So they're all pretty busy with all of these clinics, their inpatient population, and all the surgical procedures that they have scheduled. And then one Wednesday a month, their clinic is pretty busy with Heartland Cardiology coming in to see cardiac patients from the community. And so with all of this, it's really hard for the providers to try to do any other educational things or focus on any other kind of care management for their patients, because they're pretty stretched thin between all of those things. And so, they will try to provide some education at the appointments, but usually the appointment can't last too long, if they're trying to fit all these patients in a day. So they don't have much time to educate their patients on these chronic diseases. And so, that being said, a new perspective really needs to be pursued within the inpatient setting to help improve those patient outcomes and really crack down on readmission rates through some tertiary prevention. And that will kind of take away from the concerns and stresses of the providers, feeling like they're not doing everything they can for their patients. Having this other nurse involved in kind of running around and doing those educational things where needed can really help them and kind of help them have a bigger picture of their needs of their patients. Because sometimes the patient might not, they know the provider's busy, they know that, maybe the provider was in seeing them 10 minutes late. They were supposed to be seen at 2 o'clock and now it's 2:10, 2:15. The provider just got in with them and they know that they're really busy, needing to try to get them done within the hour or 30 minutes, whatever time is allotted for their appointment, to see somebody else. So they might not really go into detail of how, they're starting to have a little bit of shortness of breath with exertion or things like that. Some clue signs for some exacerbation of their CHF, or maybe their blood sugars have been high for the last couple weeks or something like that. And, if he asks if they're doing okay, yeah, I'm okay, just so that they're not bothering the provider any more than they feel like they are. So having this additional person can kind of help that also. They could call them. There would be somebody secondary that they could connect with, and also could be a liaison between the patient and the provider, and that would really help these patients with their chronic care management. The strengths of having a staff member within the inpatient setting of a hospital providing this chronic care management for diabetes and CHF include that the Cerner system is used as an universal in the hospital and the 3 clinics. And so education and any reconciliation of medication that may be provided can be viewed at all locations and can be pulled up by the provider at any setting, if they're at the clinics or at the hospital seeing the patients, or maybe they're just wanting to review some of those things that might have been provided for the patient. They can do that, and it gives it better continuity of care for the patient. With the small rural size of the community, the patient can walk in for consultation or call the assigned staff member at any time for questions or concerns. The Mineola Clinic is connected via hallway to the hospital, so that would allow providers and nurses at the clinic to utilize that assigned staff member to provide some education or referrals right then. And once the program was in place, other chronic diseases could be addressed. At the current time, diabetes and CHF are the big readmission rates that this facility has right now. So that would be the main focus right now. The weaknesses of not having this program would be that readmission rates are going to continue to climb and the patient outcomes will become grim. There's probably going to be some deaths from either a blood sugar that was not caught and either spiked or dropped drastically and was not caught in time, and they could not resuscitate the patient, or the CHF has caused too much tissue damage, organ damage, and so they're just become in their final stages of CHF. Reimbursement will continue to decline because the continued or even increased number of readmission rates, it causes penalties, and so they get less reimbursement, and that can really have a big impact on what kind of services they can provide if their revenue is not staying up to where it needs to be. Patients maybe even will look at other facility options if they see if their ratings are really poor from just the readmission rates. The outline of how this program would work, the staff member would be an RN or an LPN, and they would work Monday through Friday, 8 to 4, or you could adjust the hours as needed, whatever you feel like the need is. If those hours aren't really beneficial, if you needed to make it longer, make it 9 to 5 or 7 to 3, whatever you've determined is best for your patient population, that could be adjusted. Their main role would be to provide education and support to the inpatients with diagnosis of diabetes and/or CHF. Sometimes those go hand in hand, so it just kind of depends on the diagnoses they have. The nurse would also be available to see clinic patients as needed during those scheduled hours. She could either go, or he could either go over to the clinic. The patient could come to them, either way. The nurse would be available by phone every other weekend to take calls. If somebody came into the clinic on a Saturday in the morning and they were having some issues, she could be called. If the patient called the hospital and had some questions, they could be referred to her to call her. The nurse would be funded as a regular staff nurse, being paid hourly, and depending on the experience, would start at either the base wage for either an LPN, which is 18 an hour, or RN, which is 22 an hour for this facility. They would also be able to maybe apply for funding if it's present to reimburse. But the biggest thing is, though, it's going to pay for itself because you're going to improve these patient conditions. So you're going to have less cost on supplies and procedures because you're keeping them out of the hospital and you're having that decreased readmission rate. So your penalties from readmission rates for these patients are going to improve, and you're going to have more reimbursement available there. So it's kind of going to pay for itself. But like I said, maybe there is the application for funding that could be done. There has to be some funding grant money out there that could focus on this, and maybe they could do a little bit of both until it gets up and running. During evening and off weekends, the hospital nurses would be able to answer questions of the patients and pass on the call and information that they gave to the patient to the assigned nurse during the next working hours, so they could follow up with them and say what they recommended to you. Did that work? Do you need any other help? The nurses on all shifts would be educated on the best practices to educate patients when the nurse is off or gone. She would have the brunt of the workload, but they would be educated alongside of her to know exactly how to answer the patient's questions, how to maybe guide them in the right direction when he or she was unavailable. And once the program was fully established and going for the diabetic and CHF patients, other chronic illnesses could be added in there that are prone for readmission rates. And basically how it would go about is that as soon as the patient is admitted, and if they have diabetes or CHF as a diagnosis, the nurse would be involved from day one in ensuring that they have everything they need. Maybe they were just recently diagnosed with diabetes and they feel like they can't afford their diabetic medication, or maybe they don't have a glucometer at home. There are ways to get those for free, or maybe she can figure out another combination to talk with her provider and maybe see if they could do a different kind of insulin if they are insulin dependent. She could maybe teach them more on diets and kind of be more in depth with them. Right now what they're doing is they're trying to do some one-on-one education and providing them paperwork, but she could be more in depth. She would be there Monday through Friday while they're inpatients and even meet with them every day. What's happening now is the floor nurses are trying to do their regular job plus try to do that education, and so the split there, they're not able to give as much time as they would like to give, and she could be solely focusing on that. And she could have other ways of educating them, maybe even if the family's involved, educate them, and having everybody involved, and maybe even bringing in the dietary staff. It would be a big, complete picture, and it would be really beneficial to these patients. Overall, this program being implemented is going to help not only the patient, but the whole facility, and it will make it a better facility. They'll even maybe get in some patients that come in just to meet with this assigned staff member during her working hours, his working hours, and it could be a huge improvement in their patients' outcomes and overall the whole facility outcome. These are my references that I used for my research. Thank you for viewing this video. Have a great day.